Hello everyone, my name is Mohammed Ajab. I'm one of the internal medicine residents in Amita St. Francis Hospital in Evanston, Illinois. I have an interesting patient to present to you on behalf of our team. Our patient is a 78 years old Caucasian lady with past medical history of pulmonary sarcoidosis that was diagnosed 12 years ago. The disease was discovered incidentally. She did not have any specific symptoms at the time. She did not require any specific treatment. She presented to our hospital with 1 month history of generalized weakness, weight loss, back pain, and mild abdominal discomfort. Physical examination was significant for spinal tenderness. Shifting dullness was positive, indicating ascites. She also had lower extremity weakness without sensory level. Laboratory workup showed normocytic anemia, hypoalbuminemia. Calcium was elevated when corrected to albumin. She also had deranged liver enzymes. Imaging studies in form of MRI of the spine showed multiple lytic lesions involving the vertebral bodies of the lumbar and the thoracic vertebrae. You can see here in these T2 weighted images hyperintense lesions involving the vertebral bodies of the lumbar vertebrae. A contrast CT of the chest showed bilateral calcified pulmonary nodules. A non-contrast CT of the abdomen showed ascites, nodular hepatomegaly, splenomegaly, and bilateral renal regions. Our patient underwent biopsies from the liver and the bone marrow. The bone marrow biopsy is showing granulomatous inflammation with multinucleated giant cells. The liver biopsy showed the same findings. Special stains for Mycobacterium tuberculosis was negative. Immunohistochemical staining for CD31 was also negative. Kappa and lambda in situ hybridization did not demonstrate monoclonality, so these plasma cells were polyclonal. Our patient was diagnosed with multisystemic sarcoidosis involving the vertebrae. This diagnosis was made based on the past medical history of pulmonary sarcoidosis and the findings on the pathology. The other differential diagnoses were also ruled out. Sarcoidosis generally involve the lungs, the skin, and the lymph nodes. However, subclinical involvement of other organ systems is not uncommon. Disseminated extrapulmonary sarcoidosis is very challenging to diagnose because it presents with non-specific symptoms, and it's mainly a diagnosis of exclusion. The differential diagnoses to include are Mycobacterium tuberculosis infection, histoplasmosis, systemic autoimmune conditions such as Crohn's disease, and malignancies such as lymphomas and multiple myeloma. Biopsy is the gold standard to diagnose extrapulmonary sarcoidosis. Steroids remain the mainstay of treatment for extrapulmonary sarcoidosis as well. The relationship between sarcoidosis and malignancy is questionable. It can be bidirectional. There is an apparent increased risk for malignancy in patients with sarcoidosis, and it was reported that sarcoidosis can be also a paraneoplastic phenomenon. In conclusion, our case illustrates the rarity of multisystemic sarcoidosis with osseous involvement. Our patient improved with steroids. Her back pain improved. I'll be happy to answer any questions. My email is muhammadagab@amitahealth.org. Thank you very much.